Hello, good morning, honorable faculties, delegates. I'm happy to be a part of this sixth Anup Master Course, and I thank Dr. Ashish sir and his team to give me this opportunity. So, as the picture depicts, we're talking about uh, a trapezoidal gap, tight lateral compartment, higher poly, need of constrained implants, and soft tissue releases, common nerve issues. Yes, we're talking about valgus knee deformity. In this case, it's a 37-degree valgus knee, and how did we manage it? So first of all, I'm Dr. Kalyan. I'm a FNB Arthroplasty Fellow working under Dr. Ashish sir and his team. So, brief history of the patient. She was a 75-year-old female with hypertensive comorbidities, and she was bedridden due to knee pain, bilateral knee pain, since 3 years, and her BMD was minus 3.5. She presented to us with inability to bear weight on both limbs since 3 years and with visible deformities of bilateral knee joints. However, on evaluation, she had bilateral valgus knee deformity with recurvatum in both knees. Her range of movements in both right and left knee, there was recurvatum of 0 to 20 degrees and flexion was from 0 to 100 degrees. She had a valgus deformity of 37 degrees in right knee and 31 degrees in her left knee, which was obviously correctable to neutral, and where MCL was intact bilaterally. That's grade 3, Ranawat sir's classification. So these are the few clinical pictures of the patient, and we hardly made a stand with support. So, and supine images and lateral images showing the recurvatum deformities. However, both her knees had recurvatum. So this is a video showing her, just a second, the status of the MCL, which was correctable to neutral. Uh, so the same was with the other side, the right side of the knee. Sorry. So this were the X-ray images of this patient. For the first one was the scanogram, where in the AP view we can see the defect in the tibia side, but actually there was a hypoplastic distal and posterior femoral condyle also along with this. So how did we manage it with the Mako robot? In the Mako robotic workflow, we have segmentation, preoperative planning, tracker placements, then we do bone registrations. We get to do the predictive gap balancing. Finally, we achieve bone cuts, then trial implantation. So how did we go ahead? Surgical planning, in this case, we had pre-operative CT scans from hip to ankle. Apart from knee CT scan, we also take few cuts from the hip and ankle to get the mechanical axis. So obviously after the Mako planning, we get the gap determination, basic gap determination, and component sizes, and along with the bone defects. So in all the cases, usually we go through midline medial parapatellar approach and predictive gap balancing intraoperatively. So what are all the challenges we had in this case? So osteoporotic bones and deformity was due to tibia and femur both. She had recurvatum deformity and correctable valgus deformity, and ligament balancing was an issue in this case. So pre-operative plans, this was before after segmentation. She had a femur and tibia components of 2 and poly of 9 with 3 cuts on the lateral distal femoral condyle and 2 lateral tibia cuts. So after going into the surgery, these are the bone registrations we do. We obviously mark the femur and the tibia to register. During the predictive gap balancing, what we do is giving stress on the medial side and the lateral side to achieve get the gaps, how flexible are the gaps, and through that we got the 37-degree valgus this thing, and there was 22 of medial compartment laxity. So due to the defect in tibia, we had to use the spoons, spacer spoons. By using these spacer spoons, we got a chance to mask the defect and then take the flexion and extension gaps. So after the predictive gap balancing, that is balancing the entire flexion and extension gaps, so we achieved 3 degrees of valgus in femur and 2 degrees of valgus in tibia. with no bone cuts almost on the lateral and femur side, lateral tibia and femur side, which with 3 degrees of flexion component. So overall, we try to balance the knee. This is before taking bone cuts. We achieved a rectangular gaps of 18, 18, 18, 18 on all sides, on extension on flexion sides. So intraoperative, this was an image of haptic bone cuts of the distal femoral condyle. These are the haptics. So we didn't get a chance to cut on the lateral cartilage, lateral condyle. But however, there was a thin wafer of cartilage which came out with the saw. These are a few clinical pictures of intraoperative. Uh, we had to use a stem in the tibia, and we went with PS knee. This is the posterior stabilizing femoral component. So after placing the implants, we finally got 19, 19 and 19 gaps, which was, so we had to choose 11 poly in this case, and intact patellar extension mechanism. These are the post-operative exercises. We are waiting for the 6-week follow-up of this patient. So learning points, what we have learned in this case was we went with one medial parapatellar approach with minimal release of the soft tissues. We didn't go with any intramedullary rods, jig systems, no referencing systems. So minimal bone cuts were achieved and minimally constrained implants were used. So these are one of the few papers which support our surgery. Predictive gap balancing reduces the extent of soft tissue adjustment required after bony resection in robotic assisted total knee arthroplasty. So overall results demonstrate that rate of soft tissue release is reduced when performing total knee arthroplasty with predictive gap balancing. So thank you, sir. Thank you, sir. Any questions? Any questions? Thank you, sir.
I'm very thankful for all the speakers and you would invite Dr. Nakesh to moderate the next